So thank you very much for your kind words, Fatima, Shirlane. It's my pleasure, and I would like also to thank the organizing committee and to congratulate them for this wonderful meeting. So the topic I'm going to try to cover is new agents in gastric cancer, and of course all the content I'm going to give you from now on is essentially experimental agents. Those are my disclosures, and first I would like to tackle that issue of comprehensive molecular characterization of gastric adenocarcinoma, because I think it's starting to be useful in order to classify patients, to try to design proper experimental approaches or proper experimental treatments to address these different diseases, because as you know, gastric cancer is a very heterogeneous disease. So we know already that despite in the metastatic setting the frequency, the prevalence is very low, Epstein-Barr virus and MSI are strongly immunogenic, and they may benefit from checkpoint inhibitors. However, to try to be more concrete, I would go for the chromosomal instability subtype, which is a significant proportion of gastric cancer patients. And we know that many of these chromosomal unstable gastric adenocarcinomas may have tyrosine kinase receptor activation, and this activation could be mutually exclusive sometimes, but in some other cases there is a co-amplification, and several signals are involved in this very specific process. In particular, we can consider that among the receptor tyrosine kinase activation, we may have especially the fibroblastic growth factor receptor 2, KRAS, which is not a mutant. KRAS mutations are present in less than 1% of gastric cancer. Most of these molecular alterations will be KRAS amplifications of a wild-type phenotype. We have, of course, you know very well, RBB2, and we have EGFR and MET. So, but again, in 60% of patients, these tyrosine kinase receptors are not activated. So, despite that, this observation is tackling very specific and very small subgroup of patients, and I think we need a kind of diagnostic revolution, trying to better understand that even in prevalent in high prevalent diseases, we have small rare subgroups that should be approached in a very specific way. So this is the general picture, and so far what we have been doing when using targeted agents, whatever antibodies or tyrosine kinase inhibitors, most of the trials have not been molecularly oriented, and this is the reason why, except perhaps in the TOGA trial, which is showing a clear benefit of HER2 blockade in HER2 amplified gastric and gastroesophageal cancer patients, the rest of the approaches in first line, including anti-angiogenics, including anti-EGFR antibodies, including MET inhibitors, are all of them negative. So another important issue we have to consider when applying targeted therapies for gastric cancer is the tremendous tumor heterogeneity. And there is a wide discrepancy, for example, when we consider HER2 amplification from the primary tumors, even from some areas of the same primary tumor, or in metastatic disease. And this heterogeneity is making this approach more difficult. Going to the FGFR molecular alterations in gastric cancer, there are many, and they are common not only in gastric, but also in gastroesophageal junctions and lower third esophageal adenocarcinomas. Most of the molecular alterations we can find in this group of patients are protein expression, perhaps the most common one, about 10% of patients, activating mutations, oncogenic fusions, those are very predictive of effect when the FGFR pathway is blocked, but also autocrine or paracrine signaling, angiogenesis, epithelial mesenchymal transition, and the regulation of binding patterns. So we need to know better, and this is a very extensive and very comprehensive analysis of a series of more than 6,500 patients, in which molecular alterations of FGFR were studied in a retrospective way. So when we look for wild type, this is the majority of patients, almost all of them are wild type, and then we have small variations, we have amplification, and we have fusions, and that are very rare. So when we do trials, then from the total number of gastric cancer patients, we have to go down to a very small one when we are selecting patients that are somehow dependent on this specific activation. Those are some of the FGFR inhibitors that have been studied in the clinic, not specifically for gastric cancer, but including other squamous tumors or other, in general, tumors that may be related to this pathway. The only one I'm going to consider to expand a little bit is a phase 2 trial. Is the only randomized trial we have with this compound, this AZD4547, which is a selective pan-FGFR inhibitor. And this is compared in second line with paclitaxel in advanced gastric carcinoma with FGFR polysomy or gene amplification in a randomized phase 2 trial. So patients, almost 1,000 patients were selected, were screened for this trial, but only 71 were randomized. So this is a very small, very exploratory trial. But when we consider those molecular alteration, response rate, I mean anti-tumor activity, was very low, very limited. And also differences in progression-free survival couldn't be observed in the global population, and also when the analysis separated patients with FGFR polysomy of FGFR amplifications, no differences could be found. Another interesting antibody is bemarituzumab, is an antibody which is tackling the external part of the FGFR receptor, is a very specific, and also is an IgG1 antibody, so able to produce antibody-dependent cellular cytotoxicity, which is also another added mechanism that is of interest for this type of antibodies. This antibody is under development. Only the first part of this comprehensive plan, starting for phase 1, then phase 1 in combination with Folfox, and then these data were presented this year at ASCO GI. They are almost ready to go for the randomized phase 3 part of the trial, in which this compound is going to be compared with in a placebo control trial design. Concerning the second subtype, which is RAS-amplified gastric cancer, is very interesting because only few tumors do show this RAS amplification. And if you look at the list in this nice article published by the group of Adambas, 16% of patients with esophageal adenocarcinoma and 12% of patients with gastric adenocarcinoma, but only those with the chromosomal instability subtype do present this type of alteration. When we consider, for example, on the right of the figure, stomach adenocarcinoma, which is non-chromosomal instability, almost is never presenting this molecular alteration. And this RAS amplification is important for prognostic issues because patients non-amplified may enjoy better outcomes when compared in this retrospective series with patients showing this RAS wild type amplification. But the good news from translational studies is that when we target these wild-type KRAS amplified gastroesophageal cancer cells in animal models and combining MEK inhibitors, which is inhibiting the MAP kinase pathway, with a combination of SHP2 inhibition, those tests in vivo show great synergy between these two type of compounds, and then this is given perhaps option to do a randomized study or a phase 1 study trying to confirm the interest of this combination in patients with these specific molecular alterations. I was talking before that HER2 was the only successful approach for patients for targeted therapies in gastric cancer. But if you look at the results, the only successful approach in gastric cancer so far has been the addition of trastuzumab. When other approaches that are extremely successful in HER2 amplified breast cancer were studies, these were really failing to show an improved survival. Although we have some data on lapatinib showing increased anti-tumor activity, but no effect on overall survival. So we have to promote, and at this moment there are several compounds that are very interesting for the development of this HER2 blockade strategy, and I will focus particularly in some specific dual antibodies and also in combinations of antibodies with toxic agents. So this is trastuzumab deruxtecan. Is a combination of the standard trastuzumab antibody with a topoisomerase 1 inhibitor, which is similar to irinotecan. It's not irinotecan, but it's very similar in the mechanism of action, so is more active than other toxic agents linked to these new antibodies, conjugates, in gastrointestinal tumors. So this antibody has been already studied in a group of patients with HER2 amplified gastric cancer, progressing immediately after trastuzumab. Essentially, the drug is, as I told you before, this combination making this dual effect, the effect of trastuzumab able to block HER2, but also because a relevant part of this agent is the topoisomerase 1 inhibitor. This combination can also be active in patients not presenting HER2 3+ amplified. Could be just as an anchorage to allow the introduction of the drug conjugate part into the tumor cell. The results are very limited. It's only a phase 2 study in selected patients progressing to trastuzumab, and despite this progression to trastuzumab, when trastuzumab deruxtecan was applied with a relatively tolerated toxicity profile, Then confirmed response rate of 43% was observed, with a total disease control of about 80%, and median progression-free survival for this second strategy against HER2 is 5.6 months. There are some other drugs under development, depending on the mechanisms of resistance to these agents. For example, we have this bi-specific antibody, which is tackling not only HER2, but also HER3. You know that the heterogeneous, the heterodimerous HER2, HER3 is one of the main mechanisms of resistance of HER2 blockade. So having this drug developed may also help in tackling this specific issue. Just a few words on PARP inhibitors, because they are being studied. Olaparib was studied in a randomized phase 3 study that failed in showing any effect. But there are some new ones that they look like very active, and they are given after induction chemotherapy as maintenance therapy in a placebo control design. And those trials are now under accrual of patients. To end my presentation, I would like to tackle also the issue of diffuse gastric cancer, which is a very poor subtype of gastric cancer, not responding to chemotherapy, having a very poor prognosis when localized disease, and even time to progression in patients with advanced disease is very limited. So this specific antigen, Claudin 18.2, it is of interest because it's only expressed in tumor cells, mainly in patients with diffuse subtype. And there is a phase 2 randomized study of an antibody, solvetuximab. This is the initial data. Out of 260 patients screened, 54 were positive for this antigen, and in some of them, in monotherapy, there was some anti-tumor activity from solvetuximab. So this antibody has been also given in the FAST study in a randomized manner with addition to chemotherapy with oxaliplatin, epirubicin, and capecitabine, with 2 different doses of this antibody. And this exploratory phase 2 study is showing a positive effect in disease-free survival and also overall survival. And nowadays, a big randomized phase 3 trial is underway for patients with Claudin 18.2 positivity, to try to check on this hypothesis to get incorporated into the clinical practice if is proven to be successful. So that's the summary of my presentation. I would underline the fact that we are facing an era where we have to subdivide to recognize those specific biomarkers that are predictors of some effect. And I think targeted therapy for gastric cancer is not at all a type of treatment for all comers, but rather for a specific subgroup we should properly identify. Thank you very much.